How does my voice sound to you? Is it good? Free of distortion? Sean?
Yes, we can hear you just fine.
All right. I'm Dr. Deukmedjian, CEO and founder of Deuk Spine Institute. And we're getting ready to perform our last surgery for the day. This will be a Deuk laser disc repair, Deuk, D-E-U-K, laser disc repair on a patient at L5-S1. Our patient has a badly pinched nerve on the left side at L5-S1 due to a herniated disc and bone spur. And let's take a look at that MRI again. One more time. Let me come over there. Scroll. And the other way. All right. Do you have another view we can look at? Axial. So, first of all, when it comes to treating patients with symptomatic herniated discs in the lower back or neck, scroll down. Often you find yourself looking at the MRI and saying, wow, there's more than one herniation. Rarely do we have, keep going, a patient that has one single herniation that says it all, that's causing all their problems. Rarely. The vast majority of the time, it's 2, sometimes 3 herniations. Okay? Oh, that's why. It's not making any sense to me. I'm looking at the MRI going, it's okay. We'll get it changed. I'm looking at the MRI thinking, I don't see that L5-S1 herniation. So we had a different patient's MRI up. Why do we broadcast live? So you all get to see what it's really like. That's what happens in the real world. Sometimes we as human beings, we get sidetracked a little bit, but we figure it out. That's why it's important to have, take your time and double check, triple check everything. So I was just triple checking and I noticed that we had one of our other patients' MRIs up, but that's okay. Don't worry about it. But always check the name. That's just a lesson to learn, right? That's why I always verify things, Yeah, there's a huge L5-S1 herniation. Huge. All right, good. Leave it. So I wonder if we can block the name. Do you have any sticky pads, like Post-its? No? You see that purple tape? That purple in front of you, the 3M? If you pull off a piece about 6 inches, 8 inches long, and just drape it over the computer, you won't see the name. So let's make sure. And then can you look over at the laptop? Okay, that's fine. That's good. Just leave it. All right. Can you see the laptop? Let me have something I can point with. We're going to get started.
Yes, we can now.
Can I see the live stream on the computer? On one of them? All right, so anyway, the reason I'm showing you this, we don't do this very often. We don't do it because we don't want to. You guys are welcome to look around the operating room if Sean wants to do it, but we can't really let you see. There it is, perfect. All right, so great job, Sean. I got to give you a lot of credit for that. You all see the herniation right there, right? Where I'm pointing. That's a big herniation, L5-S1. That's what we're going to fix. There's a ginormous tear there, and she has weakness in her left foot. So we're going to go unpinch that nerve. All right, you can take it off, the MRI. Great job. Thank you. Don't take your hand off the name on the board. Okay, Dr. Deukmedjian here. Are you comfortable? Do we build the body up more with the pillows and stuff now? That's why the head gets to go lower. No neck pain, right? It's amazing what happens when you do it right. All right, this is my hand on your back. Okay, we're going to put you to sleep in a few minutes, but I need you awake in the very beginning. I'm going to put some medicine. You'll feel a little stick and burn, okay? Don't be upset. It's just for a second, okay? A little stick and burn, and that's just the medicine going inside, okay? I'm sorry, just for a second. If you have pain, say or just say ouch. But don't move your body, okay? We're going to put you to sleep very soon. Don't worry. I know. This is the worst part where I have to numb it up. All right. So we put in about 6 cc's. How's our BP? Good? My gosh. You are on fire today. I am impressed. In a good way. I get impressed easily. But not in a good way easily. I'm usually impressed in a bad way with people, not anesthesiologists necessarily, just people in general. I'm very hard to please. At least my wife says that about me. Sorry about that. Don't worry, we're going to give you a little bit of numbing medicine. Just be patient with me. So, I'm Dr. Deukmedjian. I'm the founder of the Deuk laser disc repair procedure, which is the most advanced surgery in the world for treating herniated discs in the neck and the back. Now, to be able to create a surgery that's so advanced, you really have to be able to do pretty much all the other surgeries first, and then you know that what you're doing is better. All right, let's just take an AP. And that's exactly the case. As a spine surgeon, I'm capable of doing any other kind of spine surgery available. And the reason why this is the best procedure is simply because it has the best outcome. For no other reason. What is a surgical procedure if it isn't its outcome that's important? Let's go to a lateral view. The outcome is everything when it comes to surgery. The outcome. And the word outcome means how things turn out to be. An outcome can refer to the size of the incision. It could refer to the amount of pain relief a patient gets. It could refer to the complications that they get. And all of those things are part of an outcome. Okay? So if you're talking about outcomes, you're basically talking about everything that's important with respect to a surgery. So surgical outcomes are how, in my opinion, good doctors gauge their results. Lay still, okay? Everything's all right. Just don't try to get up. Shot. Now we're approaching the L5-S1 disc, and I'm doing it as lateral as I can go. Anybody want to tell me why? Shot. Feel the facets. Let's see who's been paying attention. I won't ask my staff because they all know already. Does that feel anything back there? I'm going to give her a little bit more numbing medicine. So who knows the reason why I want my approach to be lateral? So just so you all know, medial or midline is here. If I'm here and I want to go medial, I go this way. If I want to go lateral, I go this way. Lateral means to the side of the body. Why do I want to be as lateral as possible for this particular surgery? The answer has everything to do with the location of the disc herniation. This patient's disc herniation is medial. So I have to get medial. And to get medial, you have to start lateral. Shot. As crazy as it sounds, It is the absolute truth. Shot. That was taught to me by one of my mentors, Dr. Anthony Young. Shot. And he is exactly right about it. To get medial, you have to start lateral. Shot. So, no secret there. But an important thing to take into consideration when doing this type of surgery. So I'm happy with our alignment, like our lineup. We're heading right for the L5-S1. I just need to be a little bit more anterior because she has some big facets. Shot. Her facet joints are enlarged. Shot. What that means is she has arthritis in her facet joint. Shot. And that arthritis of the facet joint is going to block, shot, my access to the disc space because it's going to push the needle laterally. No great secret, but it is the truth. Look how perfect that lineup is to the disc space, okay? So for those of you who are wondering, you can see the needle on the left side coming towards the middle of your picture. Right at the tip of the needle is the facet. It's called the superior articular process of S1. AP, and I'm in the foramen now, and I'm below the exiting nerve root. I'm below the exiting nerve root. So it's very important. You want to be below the exiting root, and you want to be lateral to the traversing root. So believe it or not, when I learned this technique first, I had no clue really. I mean, I kind of had a clue, but not really what I was doing. I know it sounds strange. I was a board-certified neurosurgeon when I learned the technique, and I had done many, many, many spine surgeries right in this area. So I had a really good knowledge of the anatomy, but not what I have today by any means. Much better knowledge today than I did back then. And that has come with basically paying attention to the three-dimensional anatomy. I can feel the herniation right now. You feel anything? Huh? A slight pinch where? AP, where? In your back or in your leg? In your back. Okay, good. Well, we're right where the herniation is. So I'm going to be able to put you to sleep soon, okay? Did you have much back pain? Perfect. Leg pain. How much back pain? Well, how much back pain do you typically get every day? What percentage is leg, what percentage is back? No. Okay. So the back pain isn't so much. But you haven't been doing very much, right? You haven't been doing much activity. Shot? Huh? Oh, right. Uh-huh. And that's not too much work, or is that a lot of work? Shot? I know how it is. I have a daughter myself. She can be a handful sometimes. Shot? All right. But, of course, a joy most of the time when she's not fighting with her brother. You know, when she fights with her brother, I get worried. My daughter is... Oh, yeah, they do. She's a year and a half younger than my son. My son is a year and a half older. He's 15 and a half. She just turned 14. And she's a dancer. Yeah. And he's a black belt in Taekwondo. And he's got a temper. And when they fight, I worry about my son. You see, my grandfather was the champion Greco-Roman wrestler of all of Africa in 1916, right around World War I, basically. He was number one in the entire continent of Africa. And this is real wrestling. This is not WWF. AP? They would break each other's hands. They would try to while they were wrestling. He had hands so strong he could crack walnuts just with his bare hand. Anyway, she inherited his strength, his spirit. So when she fights with my son, I really do worry about my son. Lateral. We went diving for scallops 2 years ago with all the cousins, you know, my kids. And it's one of the nice things you do in Florida. You go over to the west coast over by north of Tampa, and you can dive for scallops. And my son had a huge gash in his neck, like 3 gashes. It looked like a shark bite. And I said to him, "What the hell happened to you? You're bleeding profusely." He says, "Ariana got me." She did. She got him good. All right, are you ready? How bad is that on a scale of 1 to 10? 10. Is that where you typically got your back pain? Did you feel it go down your leg or just in your back? Just the back. Yes? All right, we found the bad disc. We're going to go fix it now, okay? You have a huge tear. That's a grade 5 tear at L5-S1. We're going to put you to sleep, okay? Count from 1 to 100 out loud for me, nice and slow. You can count in whatever language you want to count in. There you go. Shot. When you wake up, we'll be finished. Yeah, the problem with the shark bite on his neck is we hadn't even gone in the water yet. But like typical boys, he was taunting her. And that's just, it's like playing with a rattlesnake. I told him, man, she will literally ground and pound him. And she has no training in martial arts or anything. It's just natural. I tell people when I go to Mexico, I don't need a private security. I have my daughter. All right, you're okay. Everything's okay. I told her you could use your nails on me anytime as long as it's just to scratch my back. All right, so we are bringing the dilator in at L5-S1. You can see the tip of that big thing. It looks like a pencil on your left. The tip is at the foramen. It's just coming in underneath the exiting nerve root, and it's about to go into the herniation. It's literally kissing against the herniation, which you can kind of faintly make out if you have a good monitor. It's traveling along the guide wire. So, are you awake? All right. It's traveling along the guide wire right through the safe zone. The safe zone has a name. Anybody know the name of the safe zone? Any of our viewers? Anybody? Type it up real quick. Let's see how many spine buffs we have out there. Shot. All right. Take that. I'm going to take the hammer back. Is she okay? Do I need to stop or are we good? She's obstructing? Oh, the catheter? Shot. All right, so it's called Cambin, K-A-M-B-I-N, Cambin's triangle, named after Parvis Cambin. Parvis Cambin was the surgeon who discovered this approach called the transforaminal approach to to the disc. Dr. Camden practiced in Pittsburgh. Shot? And he practiced, I think, in the 80s. I don't know exactly what his tenure was, but he developed this lateral transforaminal approach. Shot. And my technique uses his technique, builds on it. Unfortunately, Dr. Camden had, from what I heard, a lot of misadventures, surgical misadventures during doing this type of surgery, but he didn't have the kind of equipment we have now. You know, this stuff that I use is the most advanced transforaminal equipment in the world. It's been modified, you know, kind of like aerodynamic evolvement of cars, how cars have evolved aerodynamically over time. You know, once you get a wind tunnel and you start doing wind tunnel testing, you can change the shape. Well, the shape of these instruments has changed over time. Laser. So when he started, he didn't have the benefit of having these instruments that we have today. So it makes it much safer and more effective using these smaller, sleeker, more neurodynamic. How do you like that? Neurodynamic. I created a new word. Neurodynamic instruments. Just like aerodynamics is a study of how airflow moves around objects, neurodynamic is a study of how nerves move around surgical instruments. How do you like that? Neurodynamic. There it is, brand new, hot off the press. Straight from Deuk Spine Institute. We've coined a new term. Look it up on Wikipedia. You won't find it. Somebody make an entry for me, please. Thank you. At least I got a chuckle out of Luis. And Luis is a tough guy to get a chuckle out of. So I'm feeling pretty good about that. All right, I think we're a little bit overexposed on the lights, if we can bring it down a smidgen. We're inside the herniated disc, folks, and there's the giant tear that we saw earlier. The blue dye is what I injected in the patient during the discogram. You saw on the x-ray machine a black color dye. It's actually, the black stuff on x-ray is clear to your eye. You can't see it. Crystal clear. But there's a blue dye that I put in there so I can see it. We call it a vital dye. Vital. And that vital dye that I use, I could tell you what it is, but I'd have to kill you. And since we're broadcasting over the internet, that's just not possible. So I can't tell you what it is. Can't tell you. Get me on a day that I'm in a good mood, and I will be happy to tell you that it's indigo carmine dye, but just not today. Just not today. So indigo carmine dye is blue, and it stains degenerated nuclear material. Nucleus material is the inner half of your disc. It's the jelly in the middle of your disc. And normally it wouldn't stain with this blue dye. It would just be white. But the reason it stains is because it's been injured, and it's got inflammation, and it's starting to be broken down and kind of shredded down. It's kind of like, I don't know the best way to explain it. Digested is probably the best word. It's fair to use the word digested because when we talk about enzymatic processes in the body, we talk about digestion. And this digestion of the nucleus material is really by your inflammatory system, by your neutrophils that release lysosomal contents, which are proteases, enzymes that eat up proteins. So remember, this tear that this patient got in her disc is a result of some type of trauma. Doesn't mean she had a car accident or a slip and fall. It just means that she had a traumatic injury to her disc sometime in the past, and that tear now has let the jelly come out of the disc. It squeezed through the tear. We call that jelly squeezing through the tear a herniation. Most people have heard of hernias when your intestine squeezes out through a tear in your ligament, your inguinal ligament, under your inguinal ligament. Can't remember exactly what it pushes through, but there's a membrane down there. Maybe it's the rectus sheath. Anyway, we all know herniations occur when you have intestinal material. Your intestines are herniating through your anterior abdominal wall. That's also called a hernia. But this is a hernia, but not in your abdominal wall. This is a spinal hernia. It's a herniation of the jelly in the middle of the disc coming out through the tear on the outside of the disc. So this kind of a herniation can cause back pain, and it can cause leg pain, leg weakness, leg numbness, and leg tingling. So 4 symptoms in the leg. Pain, we call that pain sciatica. Weakness, in other words, trouble cocking your foot up, walking, because your muscles are weak from the nerve being pinched. Numbness in your skin, in your leg or foot. And tingling. The tingling is called paresthesias. That's the medical term, paresthesias. All those are caused by interaction of the nerve with something it's not supposed to be interacting with. That's a herniated disc. So the surgery we're doing is to go in and remove the herniation part of the disc, the part that's squeezed out, and then to clean up the annulus so that it can heal properly. This patient's annulus is trying desperately to heal, but it can't. It can't because there's nucleus pulposus material wedged in between the 2 sides of the annulus. Okay? So the nuclear material, the herniated material, is blocking the disc from healing normally. It doesn't happen in everybody, but it happens in some people. We don't know why, but I mean, people get herniations. Everybody gets a herniation. There's no human being probably alive that doesn't have at least one herniation in their spine by the time they're 40 or 45. So why don't people have pain? Because you've healed it properly. You know, we all get injuries to our body and we heal them just fine. Would it surprise you that most people that hit the age of 60 have already had a stroke? And you won't even know it. They won't even know it because it happens in a part of the brain that they don't notice it. So we have injuries all the time to our body we don't even notice. Our body just heals on its own. And the way we heal is through inflammation. That's the first step of healing. Inflammation is the very first step of healing. And in the spine, whether it's your facet joints that get injured or your disc or your SI joint, the first step is inflammation. So this patient, look at that. That's pretty fascinating. All that red stuff is inflammatory tissue. That's where her pain is coming from. Right there. I'm zapping it away, cleaning it up. Yeah, she can feel it. We hear you. Everything is okay. Everything is okay, no problem. The reason this hurts is because this is where all the nerve fibers are. Yeah, this is where most of her pain is coming from, in her back and leg. And the inflammation you're seeing that happens in the back of the disc right here, where the nerve is, this is leaking onto the nerve root, and that's why patients have leg problems with their legs, because the nerve that goes down the leg starts right here. It's called a nerve root. It starts in the spine, and it passes out through a hole, the same hole that I'm coming in through. So I'm actually going in through a hole in the spine that's already there. It's a natural opening. It says exit only, but I'm going in through the back door. And the reason I'm doing that is because there is no sign that says one way only, and it only makes sense to do it this way because there's enough space to get in there safely, not damage anything, and not have to remove the bone from the back of the spine like every other surgeon has to. So I'm able to fix this herniation through a natural opening that's already there. I don't have to make an opening like every other surgeon does. If you're having a microdiscectomy or a laminectomy, then you're having an opening made in your spine that you don't want that opening necessarily made. You don't want it made at all. It's not natural. It's doing damage to your spine. Because I'm not damaging her spine with the Deuk laser disc repair surgery that I developed, I don't have to do a fusion. I'm not weakening it. I don't have to put an artificial disc. Okay?
We have a question.
We have a question. I'll take it.
One of our viewers says, I just got my lower back fused and I've been doing PT for 4 weeks. My physical therapist hurts me every time and I keep telling him that I'm in a lot of pain, but he says it's a normal part of recovery. Is it normal?
Well, first of all, we just got a question from one of our viewers. Excellent question. Really, really, really good question. The viewer says, I just had a spinal fusion done. I've been going to physical therapy for 4 weeks, or I'm 4 weeks post-op, and I want to know if that pain I'm getting at the physical therapist, is that normal? Look at that granulation tissue right there. So they want to know if it's normal to be having pain with the therapy session. So the answer is typically yes, it is. And it doesn't mean there's anything bad going on. Okay? But there's an old saying, if you ever watched Arnold Schwarzenegger when he was not a movie star, but when he was a weightlifter, okay? Many people don't know that about Arnold Schwarzenegger, but he was Mr. Universe. He was incredibly fit, and he used to work out every day, and he would say, no pain, no gain. Now, what Arnold Schwarzenegger was talking about was pain from the muscles. He was talking about muscle soreness at the end of the day. I need about maximum 5 minutes. So if your physical therapy sessions are causing muscle pain because your muscles are now being stretched and they're being reconditioned and they're sore and achy, then the pain is okay. On the other hand, if the physical therapy is causing joint pain, so the distinction is muscle versus joint. If the physical therapy session is causing joint pain, then it's too aggressive. Stand by. And they need to tone it back. Okay? Really hard to tell the difference. You know, whenever I have patients that come to me here, they always want to know, can I have physical therapy at home by my home therapist? And I always say to them, I don't advise it. I don't advise that you don't at least consult with the head of our therapy group, Dr. Schrumpf. Because Dr. Schrumpf knows exactly what exercises to do after each type of surgery. I've seen physical therapists mess people's backs and necks up many times after surgery. Any way we can make her a little bit more comfortable? I don't need a lot more time, but I do need a little bit more time. Probably 5 minutes. So the answer to your question is I cannot answer it right now without knowing, is your pain muscular or is it joint? And a good therapist will know the difference. A good therapist will be able to tell you, oh, we need to change what we're doing here. All right, everything is okay. We're going to try to give you a little bit more medicine, okay? Huh? Just relax. Everything is going really well. This is all part of the herniation right here. This stuff that I'm zapping away. Just behind the laser. That was a good question. Do you have any more, Sean? From our audience?
None so far.
Okay. Yeah, I know it's not a satisfying answer, but one thing that I vow to always do is to tell the truth. Okay? And the truth is, yeah, almost done, but I got to get through this herniation right here. The truth is that it's impossible for me to tell if your pain is muscular or if it's joint based on a phone call. It's not possible for me to tell. On the other hand, if you want to discuss it more with me, I'd be happy to discuss it more with you. You can set up a telephone consultation with me. We do that for free, no charge. Right now we do. Someday that'll change. Oh yeah, I know. But right now we do free consultation for I think 10 minutes. So if you'd like to get onto a Skype call, just contact my office and I'll be happy to look at you and try to figure out if your pain is more muscular or more joint. Also, if you want to do that Skype call, it'd be helpful to have a picture of your MRI before your surgery. Okay, so I can look at it and just see, you know, and get an idea of what the surgeon was treating. It doesn't mean they're doing something wrong, but I agree you should be concerned. The other thing you could do is talk to your spine surgeon that did your surgery and ask them, is this normal? Honestly, when I have a patient that has surgery on their spine and they're having pain after surgery, I always bring them in whenever I can. Like if they're close by, I'll bring them into the office and I'll examine them. I just want to make sure everything's okay. We're getting close. You can see how much herniation there is. It's just shriveling up and vaporizing, but it's just taken a while. It's a pretty good sized herniation, that's why. I think she's going to do just fine. You can see some calcium here. This means that the herniation's been there for a while. It has that gold color to it. You don't get that normally with nucleus pulposus. You only get that when it's calcified. This is scarred up right here. You see how that white, like, and there's a little bit of calcium in there. It's turning a golden color. That's all part of the herniation. I'm inside the base of the herniation. Now, to the left at 9 o'clock is the end plate of L5, vertebral body. To the right is the S1 vertebral body, end plate. So I'm kind of working between the two end plates. And that's what I was talking about earlier, how as a spine surgeon, when I first started doing this, I knew my anatomy really well, but boy, you learn it even better once you start doing this stuff, these kind of surgeries. Because you really get inside the disc for the first time. There's no surgery that we're trained to do where you go inside the disc. You know, this is the only one that puts you right inside the disc, right inside the herniation. Every other surgery, you're looking at the herniation from the outside, top down. Is that for me or somebody else? The phone call? Yeah, I do. Tell them I'll be there in 10 minutes. Yeah. Well, I thought it would be quick and easy, but this is taking longer than I thought because the herniation is so scarred together. It's pretty big. Sometimes we'll get the herniation out in one grab. You know, we'll get like 90% of it with one grab, just one big chunk. But this patient, it's all scarred together. All the little chunks have been dissolved. So what I think happened with this patient is she probably has had multiple herniations of the same disc. So maybe the first one was smaller, caused some back pain. She didn't really treat it maybe, and it kind of healed a little bit on its own, and then maybe re-injured it. She re-injured it again a year or two later, and then some more jelly squeezed out, a bigger piece. And then it kind of healed a little bit, partially, but never fully. So it was still weak. The tear was weak and it was still there. And then she herniated again. So typically these herniations are stepwise progression, meaning the patient has an initial event. It kind of gets a little bit better. And then they think they're recovered. And then, but the defect is still there. The annular tear is still there. It's still unresolved, unhealed. You see, it's trying to heal. That's what all the scar tissue is. It just can't heal properly. Not with the jelly in here. You have a question, Sean?
Yes, we do.
Go ahead.
A viewer is wondering, can dietary calcium supplements cause increased calcification?
All right, so one of our viewers is asking, can dietary calcium supplements cause increased calcification? That is a really good question. So if you were to ask me, can dietary calcium supplements cause increased calcification of your bones, I would say no. They've never been shown to do that. And we don't recommend people with osteoporosis just take calcium supplements dietary, because it's not enough. But the real question you're asking me, I believe, is can the dietary calcium supplements cause calcification of the soft tissues, which are not supposed to be calcified? That's a great question. To my knowledge, I don't think anyone's ever studied that, and I'm not aware of any data. Me personally, I couldn't answer that for you because I don't have that knowledge. I don't have the knowledge. I don't know. I've never studied it. I never thought about it. It's a very interesting thought. Could dietary calcium supplements affect calcification of soft tissues? So the calcification of soft tissues, when there's damage to soft tissue, is called dystrophic calcification. It's basically a pathological process where the tissues calcify, but it's really not entirely pathological because it doesn't really cause any harm. So dystrophic calcification usually is just calcium the pathologist would see in tissues that were injured. And they never really paid much attention to it. They just noted the correlation between the calcification of the tissue and damage to the tissue. So that's what I'm aware of it from. Real question you're asking though is, could supplements, dietary supplements, make that worse, so to speak? And I don't have an answer. I would have to say I don't know. Almost done. 1 minute. Yes.
The viewer who asked that question clarified, I have a lot of bone spurs. Is it associated with that?
You know, I don't really think that bone spurs are caused from dietary calcium supplementation. I'm not aware of that being the case. So I would have to say no. Bone spurs are caused from injury to a joint or ligament around a joint that causes calcification of the injured part of the ligament or joint. In this case, the disc itself can be injured and calcified, and they look like bone spurs when they get big on the x-ray. So I would say no, if I had to make a guess. All right, just about done. Oh yeah, there's a piece piece of herniation right there. Almost done. Almost done. Yeah.
Also, the parathyroid, does that regulate calcium, calcitonin, and parathyroid?
Yeah, parathyroid hormones and parathyroid glands produce parathyroid hormone, and they regulate calcium levels in the blood, and also can cause some abnormal deposition if they're out of whack. Absolutely. Parathyroid disease is known to have effects on calcium, but it doesn't cause bone spurs. Yep, just about done. I think that's about it. Let's see. The nerve is right there. Yeah, yeah, yeah. You're okay. You're okay. You're okay. Yeah. I think we've gotten as much as we can get. All right. We're done. We're all done. You did really good. You can see how close the herniation is to the nerve. We're literally pushing the nerve over to the side, kind of pushing it up towards her head gently. And you can see how close it is. It's literally underneath the nerve root as it exits in the foramen. Good job. You did really good. We're all done. Everything good? Vitals good? Nice. Nice job. All right. So who wants to see the scope? Can you see this?
Yes, we can.
This is the endoscope, okay, that we use. And I do the whole surgery through this. Here you have irrigation. That's saline, that's sterile coming in. It goes down to the bottom and cycles out. I have my port that I work through right here. It's narrower than my fingernail. You see that? And it gets even smaller through here. So there's not a lot of space. If you look right here, can you see the end of that?
Yes, we can.
So you have the hole that I work through. You also have a camera, like basically a rod lens that brings the image over here back up. And then you have an irrigation shaft where water comes in. And then you have a light shaft where the fiber optic light goes and shines over here. So there's really 4 things in there. Let's take a look at the incision. Here's the incision. Can you all see that? 7 millimeters. Just lay still. You're doing good. Surgery's over. I think it went well. I think her leg is going to be better. I feel like we got probably about 85% of the herniation out. No one ever gets 100. It's impossible to get 100%, but we got probably 80 to 85% is my best guess. I think that's going to take her symptoms away once she gives it time to heal. We'll find out. All right, any more questions from our audience?
None right now.
So you've seen a Deuk laser disc repair with the surgery. EBL is 1 mil. That's 1 milliliter of blood. No complications. DLDR, left, L5-S1. The only place, folks, you can get this state-of-the-art surgery right now is at Deuk Spine Institute here in Melbourne, Florida. Does it make a difference? Absolutely. Absolutely. Over 1,000 surgeries with 0 complications. That's your safety right there. That's what matters, is your safety. You want to go in, have a surgery done, and not die from your surgery or be paralyzed or have an infection. And this is the only spine surgery in the world with 0 complications. So it's the best. Plus it has the highest success rate. I'll head over to the conference room in a minute and we can answer some more questions. So start typing. All right, well, I'm being told we have no questions at this time. This is Dr. Deukmedjian. You have just watched Deuk Spine Institute's live broadcast of spine surgery for Wednesday, April 1st, 2020. We broadcast live, real time, free, over the internet, around the world. We have viewers as far away as South Africa, Dubai, Canada, Russia, China, South America, even Santa Claus and his reindeer. And we broadcast whenever we do surgeries. We broadcast each and every surgery as long as patients give us permission. We don't identify any of our patients by name or any information. For the most part, as you can see, it's just a back or a neck. And the reason we do all of our broadcasting is for public education, just to be able to interact with people out there that have a common interest in the spine, how you treat it, and what conditions affect it, and how you diagnose those conditions, and how we treat them. So during the surgeries, I take questions from anyone who wants to type a question in their dialogue box. We do broadcast in English, so I apologize if English is not your first language. I'm sure that someday there will be like a translation service so you can understand what I'm saying in other languages. I am the CEO and founder. I'm Dr. Deukmedjian. We perform the most advanced surgeries in the world here at Deuk Spine Institute. Everywhere from fusions to endoscopic surgery, laser surgery, reconstruction for people with degenerated spine, degenerative disc disease. We do surgery for herniated disc, spinal stenosis, radiculopathy, instability. You name it, we do surgery for it, with the exception of I don't do any infection surgeries. I don't do tumors or cancer of the spine. And I don't do what's called pediatric idiopathic scoliosis or adolescent idiopathic scoliosis. Can I do those surgeries? Absolutely. Why don't I do those surgeries? Because they're rare problems and they pose specific challenges that require specific medication, equipment, instrumentation, and most usually they require the support of surgeons like cardiothoracic surgeons or general surgeons to help with the exposure by moving livers over, stomachs over, kidneys over, things like that. So those are really complex surgeries of the spine. I do them, but I don't do them in the surgery center. We broadcast live from the Surgery Center of Viera, thanks to support from the Deuk Spine Foundation for research and education in the spine. Because we don't do the complicated cancer and infection cases, everything we broadcast is degenerative spine disease, degenerative disc disease, basically. When we broadcast, we invite all of our viewers to ask questions for clarification, and I do my best to share basically a lifetime, 50 years of knowledge, experience in the field of spine, experience in the field of hospitals, hospital management, and insurance companies, insurance management, administration, etc. So I'll speak about things that I have knowledge about. Those things that I don't know, I'll just say I don't know. I'm not the right person. There are many things I don't know, and I'm a neurosurgeon. There are many things in neurosurgery that I don't know, believe it or not. Though I was trained at one of the top neurosurgery training programs in the world in Gainesville, Florida, University of Florida, with Dr. Albert Roten. Dr. Roten is probably one of the most famous neurosurgeons in the world, if certainly in the top 5. And Dr. Roten was specially known for his anatomy, knowledge of anatomy, and expertise in neuroanatomy. He was also known for treating a condition called trigeminal neuralgia, or tic de Leroux, and pituitary tumors. But Dr. Roten was a great neurosurgeon and really could do any surgery. I was fortunate enough to be able to train under him for all 7 years of my training, and I was friends with him. If you really understand what that means, if you know Dr. Roten, he's not chummy with anybody, and he certainly was, actually he was a bit chummy with me. I don't know why he liked me so much, but I think it had something to do with my knowledge of neuroanatomy and my interest in neuroanatomy before I even met him or knew about him. And that came from medical school at USC in Los Angeles. Well, we hit it off well, and Dr. Roten wanted me to train with him and his doctors, so he invited me to train with him. I started my training in 1997 and finished in 2004. And then I came here to Brevard County, Florida, and set up the Deuk Spine Institute in 2004, basically. We had a different name for the first 3 years, but it was my first time starting a medical practice. I didn't know what I was doing. I didn't even know how many employees I needed or what their titles were. But I got some help, and I learned along the way, and I got a lot of help from my wife, son. We both went in it together and basically built it from the ground up with one employee in the very beginning. And we topped out around 85 employees, and now we're back down because of this COVID-19 virus, which we've unfortunately had to cut our hours as a result, and some of our staff as well. Long story short, what I'm getting at is no surgeon knows everything. No doctor knows everything. And the best doctors, in my opinion, are the ones that have a passion for something in medicine that can help people, but also know what they don't know and are not afraid to say to their patient, I don't know that, but let me send you to the right person who does, or let me help you as much as I can to find the right person that treats that condition or that can figure out that problem. So I realize that I have limitations despite my training being some of the best in the world at the time. I still have many limitations on what I can do to help patients, by myself. I am very focused on one thing, and that is curing back and neck pain and unpinching nerves in the arms and down to the legs. And I do it really, really well. Really well. So that's it, though. That's all I do well. I'm like that. You go to a restaurant and they have a chef, maybe a pastry chef, and that pastry chef can make the very, very best cakes and cupcakes and dessert in the world, but they couldn't cook a steak to save their life. So I'm that guy in neurosurgery. I am very good at degenerative spine problems, but I'm okay at everything else. Now, of course, I'm selling myself short here, but I don't want you coming to me for me to clip your basilar apex aneurysm because those are really complex vascular lesions. And though I probably could do it, I won't do it because I'd want you to go to the very best in the world, and that's not me, not in my opinion. So I think doctors in general should be honest with their patients, honest with themselves first, and then honest with their patients about what they are able to do and how well they're able to do it. If that happened, this amazing thing would happen for people with back and neck pain. And that amazing thing would be that you wouldn't be able to get treatment where you live. You'd have to travel to Deuk Spine Institute. Why? Because there's very few places in the world that are really, really good at curing back and neck pain. There's a lot of doctors that tell you they treat back and neck pain, from chiropractors to pain management to primary care to therapists to surgeons. But in the end, there's millions of people that treat it, but there's only about 100 places in the world that are really going to be good at treating your back or neck pain, that are going to give you a good, safe surgery where you can expect to come out of surgery well, not hurt, not worse. I hate saying this, but the reason I'm saying this, folks, is I want I don't want you, the audience, to believe that you can get the very best anywhere you go, because you can't. That's one of the messages. I'm allowed to say that on this broadcast. I'm allowed to say it because it's the truth. You see, I have an arrangement with the management that I'm only allowed to say the truth. And so as long as I say the truth, I can say it. That's the God's honest truth right there. As long as I say the truth, I can say it. Now, you may not want to hear what I have to say. You may not even agree with it, and that's okay. I don't expect to convert everybody. I don't expect everyone that listens to this broadcast to believe everything I say. But someday you will find out what I said was true. Someday you will find that out. And it's either going to be today or you already know it coming into this broadcast. Many people already know about that back pain is curable. All right, but many people don't. And that's why we do the broadcast, is because I truly believe that out of every 10 people that deal with back pain, only 1 out of 10 knows that it can be cured. 9 out of 10 have been told by their doctors, their therapists, by their family members, the nurses they know, the hospital, you name it. They've been told by somebody that they've trusted that their back pain is not curable, that they have to live with it. And that's nonsense. I like the word nonsense, because no matter where I go in the world, whether I'm in India, Russia, Germany, you say the word nonsense and people understand what you're saying. Nonsense. It is not true. It's a lie. You can get your back fixed and cured. You just have to have the right procedure. And to get the right procedure, you have to go to the right surgeon, the right facility, and have the right diagnostic test done. To get the right diagnostic test by the right surgeon at the right facility, now that's hard. That's like having the moon and Jupiter and Saturn all line up together. Yes, sometimes the moon will be in the right spot, but Saturn and Jupiter won't. And sometimes Saturn will be in exactly the right spot, but the moon and Jupiter won't. So to get all three, the right surgeon, the right facility, and the right diagnosis, to get all three lined up perfectly, it is almost an act of God for that to happen, because it doesn't happen often. It happened here at Deuk Spine Institute. I have the very best interventionalist, Dr. Bharat Patel, my partner. I have incredible staff here, and I have fortunately the right diagnostic tests that we need to figure out why people have the pain, and we have the right surgical technique to do it. So we're very fortunate that we're able to help so many people, but I still feel like I could help so many more. So that's why we do this broadcast. We do this broadcast so even if you don't come to Deuk Spine Institute, it's okay. But start asking questions. Start expecting to get better. Start expecting to be normal again. You can be normal again. I'm talking to 98% of the people out there with chronic back or neck pain. You can be normal. You can be without pain. You can go out and do what you want to do again. Now, people with osteoporosis, you got to get that treated, cured. You have to get your bones strong again so you don't have more fractures. All right? Once that's cured, then you can go out and do what you want. Okay? So we're not talking about mostly osteoporosis. We're talking about people with disc problems, spinal stenosis, pinched nerves, herniated disc, bulging disc, and pain. Those are the people that are easy for us to cure. All right. Do we have any questions? Nope. So everybody's enjoyed hearing me, my monologue, talking, and that's fine. I understand the world is hurting right now with COVID-19. So I pray for everyone out there, those people who are suffering with a virus and its effects, and I pray for those people who are not yet affected. I pray for everyone that you all make it through this well. Until the next time we broadcast, Dr. Deukmedjian signing out from Deuk Spine Institute with Sean here at my side, helping. Thank you. Peace.